the concept that we are talking about is the change in our understanding of managing type 2 diabetes, with the focus shifting from what used to be good glycemic control as our primary goal to actually looking at reducing complications overall. And certainly, even earlier, when we always thought of reducing complications, if you got better glycemic control, you had better outcomes with regard to microvascular disease, and somewhat better outcomes, a little bit more questionable with regard to macrovascular disease. However, a recent understanding has sort of changed our approach, because we are really not thinking of these as completely separate entities altogether. We are really talking of overall complications related to diabetes. Some of them are related to glucose control, some are related to hypertension, some are related to genetics, but it's about a conundrum of complications, which actually not, it doesn't just include, micro and macro in watertight compartments, but spills over from kidney to heart to overall metabolic complications, and I would actually start adding liver there. So I think this whole, all those things, and as typically understood, we start with insulin resistance and then move towards a state of progressive insulin deficiency. But we also know the role that visceral adiposity is playing in that. We know the role of inflammation, glucotoxicity, gut microbiota. The whole thing is changing from being simple pancreatic defect and peripheral defect to a combination of many things. And the advent of new therapies has actually opened up infinite possibilities, newer possibilities for preventing this progression. Of course, as you know, this CRM is a fancy, acronym. It doesn't mean much. Basically, cardio, all cardio, renal, right? And all metabolic, but the fact that they overlap, and that's the whole concept. It's not that renal disease is separate, cardiac disease is separate. The main cause of death in renal failure in ESRD is coronary events. The main cause of death in diabetes is coronary events. Now we understand heart failure as an important link between diabetes and the heart. So the whole thing is all merging onto each other. And as I said, some newer therapies help us address these all together. And that's the whole idea of this discussion. So, I mean, you know this, right? There's nothing that I'm going to tell you which you don't know, that it's not just vascular disease. It's, of course, renal failure, oxidative stress, inflammation, cellular apoptosis, but the so-called diabetic heart pump failure or pump dysfunction is actually much commoner than we think. Much, much commoner. Only the last few years have shown us that it's not only about ischemic heart disease, it's about reduced pump capacity that we see in patients with diabetes, and that's far commoner than we thought. And as usual, the focus on these things, like the focus on lipids, changed completely after the advent of statins. The focus on osteoporosis changed completely after advent of bisphosphonates. Similarly, the focus on heart failure, on heart, changed completely after the advent of newer molecules, especially SGLT2 inhibitors. So we focus on early management. The important part is glucose-lowering drugs that have non-glucose lowering actions also. So you can call them pleiotropic actions. I probably think they're primary actions, and glucose lowering may be just one of the actions of these kinds of molecules. So you obviously work towards weight management. So when you are looking to focus on your patients now, when you start treating a person with diabetes, you're not just looking at blood glucose. You're looking, of course, at blood glucose, but you're looking at helping the person lose weight. You're looking at avoiding hypoglycemia, and you're looking at long-term vasculometabolic control, all again jargon, basically meaning you're looking at strategies that will reduce the risk of long-term complications of the heart, kidney, etc. I think that's really, really important. So we all know that our A1Cs are not well controlled and everywhere in the world, and we don't do much better than that. We know that most of our patients, typically, when you recruit patients for a trial, it's a good way to look at it. And typically you find A1Cs between 8 and 9 in the OPD. So most of our patients are not very well controlled. with the advent of newer agents and more understanding, care, the numbers who are well controlled will go on improving, hopefully. But at the moment, we know that 2/3 of our patients are not achieving targets at all. There's no question about that. And as I said, our classic approach was climbing up these steps. From diagnosis, you talk, first time we were always told, don't prescribe a medicine. Dr. Hajra will remember, you just tell him to go and follow a lifestyle, come back in 3 months. We still do that, but we do that with people with A1Cs of 6.5 and 6.6, not with anyone above that. So the approach was first try that, then you try metformin, then you try a second drug, and then which is okay, which is how pharmacology was built. But now we understand that attacking it on multiple fronts right from the beginning gives us better long-term results. What is the goal? The goal of treatment is not just to keep blood glucose normal. The goal of, if you keep blood glucose normal, but you can't prevent complications, is quite useless, your whole approach. So it's about preventing complications. And for that, going stepwise need not always be necessary. Of course, there is some stepping, it can't be all at one go. But yes, we have become much more aggressive in our approach to treating diabetes in the early stages. So therefore, you climb up this, reach the goal, and therefore, in every step, there is inertia. Every step that we take, there is some inertia because of simply patient request sometimes your own lack of time, sometimes your own mental laziness, because you think maybe we can try another 3 months, let's see. So, all those kind of things happen in real world. So clinical inertia has been a big challenge in this. So, but we know that when we are treating diabetes well, even glucose control, we know that we clearly reduce microvascular complications. This is an oversimplification, this slide. There are numerous studies that have shown the UKPDS, starting with UKPDS, that even in the studies that showed that in patients with advanced heart disease or with existing heart disease, tight control like Accord and advanced special, they didn't have any favorable outcome. Even there, lowering of A1C, even at that stage, improved microvascular disease, reduced the risk of renal complications. So lowering of A1C will have benefits across this, micro and macrovascular disease. And again, its targets are important, but even a 1% lowering makes a difference. So remember that. Even a 1% lowering makes a difference. Now, there's other thing is, well, there is some data saying that glucose lowering is better with these newer agents in people of predominantly Asian ethnicity. That was mainly that was not South Asians. These were Asian, which is mostly East Asians ethnicity, and no difference with GLP-1RA. I'm still a little cautious about jumping to conclusions, because everyone gets up and says, maybe it works better in Indians. Maybe we have more beta cell defects. Maybe a symptoms work better. But I think it's a bit premature to make a definitive statement that, we know that DPP4 works better in India. I think at least I am still a little unsure. Probably yes, but I'm not certain yet. Again, this is going for you. We talked about this many times, from just a simple, as I said, liver and pancreas and peripheral muscle disease. It has now moved to multiple things that are. So if we attack multiple pathophysiology at the same time, we will get better results. And the beauty of these modern combinations like SGLT2 and DPP4, that they have separate mechanisms altogether, and they don't clash with each other. They're completely different mechanisms. Like SGLT2, we know act by increasing glucose output through the kidney and suppressing some glucagon from the pancreas. So there's no interaction. There's no possibility. It's not like combining a meglitide and a sulfonylurea, which is the wrong combination. It's having two drugs that act on two different pathophysiological aspects of diabetes. And therefore, when you look at empagliflozin, you actually, over a period of time, reduce insulin resistance. Look at HOMA-IR. And you look at linagliptin, you actually improve beta cell function. Again, no big surprises here, because one drug is acting primarily on the pancreas, that is the linagliptin. or any gliptin. And the SGLT2 inhibitors, they act by so many mechanisms, but one of them being that they do reduce insulin resistance, which is thought to be primarily because of weight loss, because of fat loss, and maybe because of reduction in hepatic liver fat that we have shown in our own studies. So when you look at all this together, if you look at a metformin and a sulfonylurea combination, it is powerful and effective, right? There's no question about that. If you look at metformin and DPP4, it's probably a little less effective in terms of potency, but very low risk of hypoglycemia, right? I hope this is clear. Right is hypoglycemia, and as you go up, as you go down, the risk of hypoglycemia decreases. So we know that metformin SGLT2 combination is fantastic for this. But if you look at metformin plus SGLT2 plus DPP4, you're actually doing everything together. Think of it. You're helping to reduce weight and blood pressure, left upper quadrant. They're powerful and early efficacious. Early efficacy, you know that DPP4, SGLT2 in particular are powerful molecules, especially when combined with metformin. The risk of hypoglycemia is really low, right? Bottom quadrant. And the left bottom shows the icing on the cake, which is actually seeing benefits in the long run. And I think that's fantastic. And when you use a fixed dose combination, I mean, I'm not going to take the data. There is no surprise there. We know that EMPA works very well. We know that LINA works well. When we put them together in an FDC, it doesn't mean that 1 + 1 = 2, but 1 + 1 may equal 1.5. Right? So you actually do get improvement in HbA1c. This is EMPA 25, LINA 5, EMPA 10, LINA 5. This is EMPA alone. So just look at this one. 0.62 with EMPA alone and above 1 with the combination. Fantastic, right? And LINA alone, again, about the same. But when you have a high baseline A1Cs, that you commonly find your patients in our OPDs when they start out with us, then you can get almost a 2 reduction. 1.5 to 2 with this combination. The idea being that if you start using these combinations early, you can get significant benefit for your patient in terms of A1C lowering, weight reduction, long-term benefits without risk of hypoglycemia or minimal risk of hypoglycemia. The risk, of course, is GTIs. We know with SGLT2 that the risk of GTI is fairly high. There is some evidence, and again, this is evidence which I still take with a pinch of salt, that when you combine SGLT2 and DPP4, it reduces the risk of genital infection. Now, it's okay. Yes, there is some evidence, but I'm not completely convinced that when you combine them, the risk of genital infections is less. But anyway, that's what, and we know that. Body weight reduction, we've all seen that. We've published that. BP reduction. One huge advantage with SGLT2 is their mild diuretic nature, which actually leads to significant blood pressure reduction. And a sustained reduction of 3 to 4 millimeters is actually really important in a long-term history of a person with diabetes, right? And you may be able to reduce one like antihypertensive, like a mild diuretic. You may be using a low-dose thiazide, which can go out of the window once you have somebody on empagliflozin. That's the added thing. And as we know, body weight benefit is a huge thing, and I'm not talking about it here today, but we've done the the E-lift study, which actually looked at hepatic liver fat. There was no time to include all that. We're talking only of FDCs. So, and there was clear reduction in published in March 2018 in Diabetes Care. Clear reduction in hepatic liver fat in the group that got EMPA in an open label study versus those that got standard of care. So all this is happening as an effect of EMPA. And despite all this, you're not getting any additional hypoglycemia. That's the beauty of the whole thing. And as I said, this is what is presented to me again and again. Maybe it's true. You can read the title. But as I said, I think we need more data to prove this kind of thing. Now, we're not going to bore you with all these studies. You know, EMPA-REG, CANVAS, DECLARE-T. We know that there is cardiac reduction in cardiac risk with the SGLT2 inhibitors in coronary events in 3-point MACE. Different studies and different inhibitors have shown something different or the other, but EMPA remains the leader of the pack by being the first one off the block. and having nothing negative really about it. So there is no question about that empagliflozin is important in this regard, but it's not just the myocardial, not just the atherosclerotic events, which I think the effect is less pronounced and little bit hazy at times. But the hospitalization for heart failure is remarkable. The effect on hospitalization for heart failure is remarkable and consistent across all SGLT2s. So in one line, empagliflozin reduces hospitalization for heart failure very significantly and possibly also helps in reducing coronary events or adverse cardiovascular events, even excluding hospitalization for heart failure. And again, there you go, CV deaths, hospitalization for heart failure. A very, very significant reduction. This is consistent. The HHF data is absolutely consistent. CV deaths was very well seen with EMPA. Some others did not show it so striking. Some others showed so I'm not going to hair splitting over differences between SGLT2s. That's not the topic today. But I think what is more important is, yeah, we know this. Right? You've seen this about 1 million times. The EMPA-REG study, the reduced risk of CV deaths was started very early. Too early to be pure atherosclerotic. That's the point we are making here. It's not going to have, so it's probably an impact on the heart failure at that point, some other mechanisms which are still being studied as to why, but the benefit was clearly seen, no question. And across all heart studies, CV outcome trials, with all these SGLT2 inhibitors, hospitalization for heart failure was one thing that stood out consistently. So the issue here is about the DPP4, and very in one line, there has been some data on alogliptin and some data on Saxa, which suggests that they may possibly increase the hospitalization for heart failure, but certainly no data on Lina to suggest anything like that. And Vinayak so neatly presented data on Lina from Carmelina, very clearly showing that it is cardiac safe in one line, both with regards to MACE and with regards to heart failure. There you are. We won't repeat this. Absolutely no difference. And of course, some impact on albuminuria. I really should have put the liver slides here. But anyway, so decision cycle for patient-centered management. Basically, we have to keep the regimen simple. We have to keep it at a level that optimizes patient adherence and persistence to treatment. When you have chronic care medication that has to be given for years and years, having separate pills or reducing pill burden makes a big difference. The fact that you don't have to time it with a meal makes a big difference. Take it any time of the day. The fact that it's a single pill will make a big difference. The fact that it doesn't produce hypoglycemia will make a big difference to compliance. So if you're talking of people and their effects, we forget that these things actually determine in clinical practice. If you're advising molecules which have to be taken half an hour before a meal, 90%, 95% of patients will not be doing that. I don't know how many doctors do that. Many doctors have diabetes, hypertension. How many will take their medicine half an hour exactly before meal? It's very difficult to manage in real world. So all these are huge advantages in addition to the advantages I already showed of long-term impact. So, right, no confusion. You can read the title of the slide. These are the ESC guidelines. And renal evidence is strong. Hepatic evidence in terms of safety is strong, but also in terms of some benefits, which we haven't shown today because of lack of time. And of course, combinations will work. There are 3 combinations available, empagliflozin plus Lina. All of them work well for glycemic control, no question about that. All of them work well for weight reduction, no question about that. All of them work well for that they don't, in the sense they don't produce hypoglycemia. But when you look at the long-term outcomes, there seems to be a difference. It is a Lina and EMPA combination that seems to be the safest for the heart. And the Remo and Vilda, which on short-term results seems as good, or at least about as good, we don't have that kind of long-term outcome data on heart. So going by this, quite clearly the EMPA-Lina combination is most cardiac friendly in the long run, proven cardiac friendly in the long run. So to a holistic, as Dr. Hajra was saying, CRM, cardio-renal metabolic approach, it does all those things together. I think it's easy to do this and in a fixed dose regimen. And I think you're not going to worry. We all know the benefits of taking a fixed dose regimen. So I think the beauty of things is in combination. This is a picture I took last week from my terrace, and the sun alone was shining. It would not look that beautiful. When you combine it with the clouds, it becomes sky art. And that's why combining things adds to the beauty. And this is where this combination comes in. Thank you very much.